Okay, so my name's Dr. Michelle Denton. I come here from a range of perspectives, and thank you for having me. I spent 14 years as the manager of the Queensland Forensic Mental Health Service, and during that time I led the design and implementation of the Prison Mental Health Service and the Prison Transition Support Service, and really designed the Prison Transition Support Service model in 2006, and the Forensic Mental Health Court Liaison Service. So that was my career. Prior to that, I managed the Brisbane North Methadone Program and the Brisbane Royal Brisbane Hospital Alcohol and Drugs Service for several years. Then I went on to complete a PhD titled Hoping Against Hope, the Prison to Community Transition Experience of Men with Co-occurring Severe Mental Illness and Substance Use Disorder. And this was the first known qualitative study in Australia to focus on the prison to community experience of prisoners with severe mental illness and co-occurring substance use disorder, with histories of repeated short-term imprisonment for non-violent offences. So that was really the specific topic. And the reason I chose that topic is because, when we set up the Prison to Community Transition Support Service, the Prison Transition Support Service, we looked at the first 100 people who came out, and 63% of them fit that criteria. So they had co-occurring substance use, they had a severe mental illness like schizophrenia. Most of my participants had schizophrenia or bipolar disorder, a couple of them, and severe, a diagnosed substance use disorder by a psychiatrist. So most of them were using IV amphetamines, so serious drug use, and they were so we looked at the first 100 people who came out of who were supported by the Prison Transition Support Service, and 63% of them fit this criteria, which then became the inclusion criteria for my PhD. So co-occurring and short-term and non-violent offences. Mm-hmm. So that's who I focused on. I thought, well, this is the majority of people that we're dealing with. Let's have a really close, in-depth look at them. And so then I did 48 interviews altogether, and they were men between 18 and 40. I interviewed them in prison and taped those in-depth interviews, and then I followed them out 2 weeks post-release and 3 months post-release and interviewed them again and looked at what their experience was. I'm also now currently on the parole board, so I'm sort of seeing a sort of live group of cases in terms of what's happening now, and I've published about the work that's come out of my thesis, and also the Prison to Community Transition Support Needs of People with Intellectual Disability. Co-authored a book chapter with Dr. Kathy Elam, and recently also did an evaluation of integrated health and housing first model that Karen Walsh was talking about, and the three-pronged approach of, and Debbie Kilroy also talked about it, that this approach of having tenancy support and social support and integrated healthcare. So this three-way model that we promote as being the best practice, contemporary best practice in terms of supporting vulnerable people, not only people with mental illness, but people with chronic physical illness as well. So, I was really excited really by the your draft report, even though I know that you hadn't got your data fully, and that I think will tell a very strong story, and particularly that recognition that prisoner reintegration is a multi-dimensional approach, which, and that you acknowledge that housing, employment, and income and ongoing treatment for mental illness and substance addictions and assistance with relationships and behavioural changes. So you've captured the main issues, a lot of has been said today majority of which I completely agree with, and I'm going to bang the housing drum again, because that's really a major issue for people with severe mental illness coming out of prison. People with mental illness, as you'll be aware, are also criminalised in the same way that the previous speaker talked about. And one of the things that came through very strongly in my research was that people with severe mental illness, like diagnosed psychotic illness in the main, they weren't in prison because of that. They were in prison because of their substance use issues and the consequences of that. The sort of what they needed to do to maintain their drug habit, which was dealing drugs or working in the sex industry or stealing to support their drug habit. That's really was the story for almost all of my research participants. So the focus, of the system was on the fact that they had a psychotic illness, they had a mental illness, but really the reason they were in prison was because of the consequences of their substance use. That came through really strongly, and it's consistent with the international literature. So what I really wanted to just mention a few points today. It's been a long day, so I'll try to keep it as short as I can. But people with severe mental illness and cognitive disability or cognitive disability, intellectual disability, often or almost always accompanied by substance use problems, leaving with prison, are confronted with all of their complex needs at once, and we've heard that several times today, but I think that's really the case. And so they're confronted with their housing, their income, their social support, and their treatment needs. And this can be very overwhelming for them without extensive support, and often results in a rapid return to prison, as has been mentioned a number of times. This group also, a number of the participants in my research said that it was so overwhelming. I mean, this group have got known to have lower coping skills than even the general prisoner population, who are also a very vulnerable group. But, what I heard over and over again in my interviews was that coming out of prison with all of those needs at once that hadn't been planned for, hadn't really in any great way, it was very overwhelming. And the sorts of things I'd say to me would be, well, all of my friends are in prison, have a dry bed, 3 meals a day, I hate being in prison, I want to get out, but it's really worse in the community, that was their previous experience. Now, why I called my thesis Hoping Against Hope is because they invariably had, the resilience of human beings is amazing, really, and they'd be like, but this time I'm really going to try and make it work because I really want to live out in the community. But their previous experience, and my participants were, on average, had been in and out of prison 7 times, so their life over, they're all under 40, so that was what they were saying. So, but the first major point I want to make is that treatment services are much less likely to be accessed if the person is homeless or living in unstable or unsupported accommodation. Now, that's a fairly obvious statement, that if you are living under a tree at the bayside or under a bridge or in a, homeless men's hostel or in a really impoverished one room of a boarding house where there are lots of other really seriously disadvantaged people and not a very, a sort of toxic culture and not a very supportive environment, then prison is looking attractive, and treatment services are the last thing that you're going to get to. Your appointment, you'll be lucky to get to your parole appointment, but getting to your mental health appointment, to get your medication, then go to the pharmacy to get your medication. These things are not going to happen if you're homeless or in very unstable accommodation, because what you're thinking about then is, where am I going to get my next meal? Is somebody going to hurt me in this environment? How just basic survival. So, treatment needs become secondary.
Just briefly there. So if someone's on a methadone program, for instance, they are going to make those appointments, though, aren't they? Because there's a physical addiction at play there that drops. Yes,
I think that's true, and I'm a big supporter of methadone. Actually, I know it's a controversial topic, but I think when people are on methadone, I managed the Brisbane methadone program. We had 800 clients on that program then, and that was in the early 1990s actually, so it's probably much bigger now. But they're using other drugs as well, other substitute drugs. But when people are on methadone, they do get to the chemist, you're right, and if they've got their couple of dollars, which they have to pay for it usually, and they tend to stop, doing break and enters or dealing or whatever else they were doing, and they tend to stay out of prison, and they tend to do quite well.
The reason I raise it, I just wonder if there's a chance to couple other services, with attendance from methadone visit each day or whatever it is. Anyway.
Yes, I think that is a good idea, and we did look at that a few times when I was doing that sort of work, and I was advocating at that point to try and link in child child support and child care and other physical health services, and we're able to do that a little bit. But
I should let you get back. I'm sorry I interrupted you.
That's right. All right. The second point that I want to make is around fragmentation of services, and that's been mentioned before today as well. And in my thesis, and withdrawn from the international literature and my own research, and I've subsequently written about it, is that there's clearly fragmentation between services in three main ways. One is the criminal justice mental health interface. So, and that's been mentioned before today about different philosophies, like with the criminal justice focus, you have, a sort of focus on risk and containment and control and punishment sometimes, and, rehabilitation sometimes. Whereas in mental health, there's a focus on, recovery and strengths-based and, sort of opportunity and, sort of support and those sorts of things. So those two philosophies don't go together very well and rub up against each other. And also there's a sort of focus, I think, within the criminal justice system and in criminology, and I think that came through with one of the speakers today, that there's very much a focus on the individual responsibility, individual risk and individual pathology within the criminal justice sort of paradigm, whereas where rather than a kind of systemic focus or structural or social focus. So those two, criminal justice and mental health, can really clash, and so it's difficult and to work together in terms of providing mental health services in prison and post-release, and particularly with parole. So parole doesn't really have parole services don't really have a mental health focus. They don't do a lot of training with their workers. I think Mr. Sofronoff made some comments around the need to strengthen parole services, and I see that in the parole board work I'm doing at the moment, that there's it doesn't seem to be a lot of focus, or there could be more, let's say, and a lot of the population have problems with mental illness. A lot of people who are coming through parole. So the first is the criminal justice mental health interface. The second interface is between treatment services, physical health, mental health and substance use provided in prison, and services provided in the community in terms of continuity of care, and that was also mentioned today by one of the speakers. And sort of So people, again, being referred to appropriate agencies, and there's all sorts of barriers in terms of not knowing when people are going to be released from prison, and also a sort of I think there can be a cultural issue in prisons that when people leave, they're no longer our responsibility, and so that sort of you go out the gate, and people are in the community, and so it's the community's problem, and the communication between the two is not always ideal. And the third interface, in terms of fragmented services, is interface between mental health and substance use services for released prisoners. So that's also been mentioned today, but in terms of waiting for a drug rehabilitation bed, and some of the participants in my research were highly motivated, knew they needed to go to rehab, drug rehabilitation, and couldn't make the direct transfer. It's very unusual to be able to make the direct transfer, and so they were waiting for 1 or 2 weeks in a hostel situation or homeless men's hostel, where there are lots of other people using drugs. They're highly vulnerable. It's it's a long wait, a week or two, and when there are people who are using drugs around you, and alcohol, and and also the availability. So one of the issues is that lack of transition system between the two. The second is the availability of drug rehabilitation beds, and the third is the suitability of the programs. That one of my research participants said, I don't go to, one of the programs because it's like going to church. There's often a strong faith-based, and I'm not in any way running those programs down. I think, the faith-based organisations do a tremendous job, but it doesn't suit everybody, especially kids or people who have grown up in institutions where they may not have been treated ideally, and, they may not want to respond to that kind of program. And so I think that it's really clear that there's not a breadth of programs to meet the needs of everyone in terms of substance use. And as I said before, not only my qualitative research, but the international literature would support that the majority of people with a severe mental illness who are in prison are there because of their substance use. That's really it's a clear, it's a known fact, if you call it that, that it's really that's the biggest issue, and and it's one that we're probably doing the worst at in Queensland, providing accessible, suitable substance use programs both in prison and outside, and the continuity of care, the transition process, and the availability, and the suitability. How am I going? So next is. And I've already sort of touched on this, is that this substantial evidence that acknowledges the interaction between the individual and the environment, that emphasises the impact of trauma, stress, substance use, homelessness, poverty and unemployment as risk factors for imprisonment for the general prison population, as well as people with severe mental illness. So the emphasis in the research literature is increasingly on a broader social context, and this is what's been said by many speakers today, and the interaction between the individual and the community they're returning to. So the community provides resources for people who are coming out of prison. That also has a need for safety and security, obviously, but problems occur during transition when communities are unwilling or unable to provide the necessary resources to the individual, who is then likely to be economically and socially isolated, engage in criminal activity of some kind to meet their resource needs. So it's a no-win cycle. I think sort of conceptually we can say that the prison to community transition experience can be viewed as an interdependent process, both of the individual's willingness and capacity to make changes, as well as the community's capacity and willingness to support the individual. And so, I think that's an important concept, that we need to support both the individual and the community that's receiving them. And I think a lot of as someone was talking about earlier, about place-based initiatives in regional areas, but we're not able to do it very well in Brisbane either. So this understanding of the social processes underlying the prison to community transition experience points to the need for wraparound support services that strategically develop individualised links in the community to enhance treatment and community supports. This includes supported housing, supported employment, active community outreach and development, individualised case management, psychosocial skill building, integrated mental health and addiction services, and a focus on both mental health and criminal justice outcomes. So that's no different from what Karen and a number of other people have said.
It's a good shopping list, though, just the same.
Yeah. So the extensive body of international and local research indicates it'll be far more. So one of the comments, and that's one of the reasons that I wanted to come today, even though I realise that I'm sort of repeating what a lot of other people have said, is that your report says a number of times, about 3 times, that reintegration services are a risky investment. So I'd like to propose that the extensive body of international and local research indicates that it will be far more risky to neglect investment in evidence-based, comprehensive wraparound services to support individuals with mental illness returning to communities that are adequately resourced to receive them. The much higher risk is in maintaining the status quo of prisoners being released to homelessness, unemployment, lack of adequate social supports and fragmented services. This will likely continue to contribute to further rises in imprisonment in Queensland of people with and without mental illness, despite falling crime rates. So I firmly believe that statement, that it's far more risky to not make this investment. So just briefly, the summary is that the needs of people with mental illness, substance use disorders and cognitive disability leaving prison are interrelated and must be addressed with a coordinated, integrated set of comprehensive wraparound services. Stable, supported accommodation using a housing first approach is a fundamental need for this group and is currently severely inadequate in its reach for this group in Queensland. Fragmentation of services between the criminal justice and mental health interface, between prison and community services and between mental health and substance use services contributes to the poor reintegration outcomes for released prisoners, especially those with mental illness and co-occurring substance use disorders, and both individuals and the communities receiving and supporting them post-release need to be adequately supported and resourced. And the 5th point is that there's a strong correlation, I think, between prisoners with a mental illness and short-term imprisonment and this revolving door. And that group's not getting very much attention. They don't have access to programs. They lose their accommodation and support services when they go in for 3 or 6 months, and then they come out again to nothing, and then it all falls apart very quickly and back in. And so if we're even able to address that group of low-level offenders with mental health and substance use issues and get them sort of stabilised in the community through whatever mechanisms, either through hostels or bail support hostels or probation hostels, and if we were able to support community probation and parole to become more mental health literate and substance use literate, to be able to support people to get to those treatment programs from a sort of relatively secure base, then we could probably make some, wins fairly quickly in terms of the number of people in prison.
Thanks, Michelle.
Michelle, I have a question.
Mm-hmm.
You talked about the shortage of substance abuse programs, both the suitability and availability here in Queensland. Why? Why is it? Why are they in short supply? Why aren't they always suitable? Why aren't they always placed available? Is this simply a funding problem? Is it that simple? Or is it more than that?
Look, I think it's largely a funding problem. I think it's also a sort of a kind of blind spot problem that mental health services are the powerful player in that space. They have the majority of the resources, and alcohol and drugs, illicit alcohol and drugs, is a problem for mental health services because they don't know what to do about it, because you can't give people more drugs to deal with their drug issue, and the main instrument of psychiatric services is to use medication to treat illnesses, right? So there's this fundamental sort of difficulty for mental health services.
So if you're a drug prescriber, a psychiatrist, every problem looks like a nail you have to bang with a prescription of some sort.
Well, you said it, I didn't quite, but yes, there is a tendency, there's a clash there's a very strong tension between the medical model within psychiatry, which is primarily about using medication to treat mental illness, and of course medication has a very important role in terms of severe mental illness, but there's a whole lot of other strategies also that are very important. They probably get less attention and less resource. But the problem with alcohol and drugs, in my view, and after working in this field for my whole career, is that model, when you're primarily focused on using medication to treat life problems and mental illness, then what to do about substance use is very problematic, because you can't give people, other than methadone and other opioid substitutes, which are controversial, but, I think potentially very useful and keep people away from the sorts of, offending behaviour that gets them into trouble. What else do you do? So, there's there's this whole other body of evidence that would suggest that long-term rehabilitation programs that are properly run and properly funded are a very important part of the picture, that there's other community-based organisations that can support people and provide counselling. It's a difficult area, but I would say fundamentally it's about this sort of philosophical or ideological clash.
It's a very interesting response. You've answered it in a way that I've not heard it responded to previously, so that was quite useful. Thank you.
Right.
With regard to the wraparound services, Michelle, how do you or who do you envisage would provide them? Do you see that as one entity in particular areas? Would it be an NGO, local council, federal or state, or a multiple agencies?
Look, I think the sort of best practice approach in terms of supporting people is to have a sort of case management model, which is so it's provided by one agency. But some of the models that have been, evaluated especially in America and pilot projects, and there's various work going on around in Australia, is that they need to be very multidisciplinary teams that have also strong relationship with parole. And, there's been some models that have been trialled where they have active parole members on the team, but that's controversial, and there's various opinions about whether that's a good idea, because you bring in the sort of control containment issue into the therapeutic recovery model, and you get that tension. But look, I think there needs to be, I think the model that was put forward earlier today, not necessarily the residential, but
The hub model.
The hub model, but in terms of a multidisciplinary approach to wraparound services with a core case management, but with very strong links across all of the different departments. So when the model was presented earlier around the need for intergovernmental steering committees, so it all starts from the top. And when we were trying to put mental health services into prisons and into the court liaison and those sorts of things, we spent most of our time working up to try and get people to talk to each other across the departments, so that we could then have the support to do the work we needed to be able to do to work across putting mental health services in police watch houses, in the courts, in the prisons.
I guess I'm trying to say is, are those workers, those case wraparound workers, are they employed by
the NGO
government
sector,
or are they employed by the NGO?
I think probably the NGO sector. Yeah. But you need complementary positions in government as well that support that. So, the general health system is starting to use positions like navigators. For example, you would have heard of that, nurse navigators, and because they've got continuity of care issues, people coming out of hospital for post heart attack, for example, and they need they're starting to employ people that they call navigators to help people access the sorts of services that they need, so they're really a process person, facilitating. So I think there's models that can be drawn from the general health system who are doing it out of desperation because it's so expensive to have somebody in hospital, even more than in prison. So they're having to find ways of facilitating those sort of processes. And we could, I think we can borrow some of those concepts. But look, I would envisage that really what you need is in the NGO sector, but that's very well supported, but also with very strong relationships with local government, with state government, with health, with general health, with mental health, with corrections, with so you need it's very complex, and obviously, as you've discovered in this review, and you need people to be talking to each other.
Absolutely.
Thank you, Michelle. Any comments from people who are here this afternoon? Yes. Please remember to say who you are and where you're from. Thank you.
Paul Bryden, Anglican chaplain at Woodford. A bit of background. I've been involved in the dementia advocacy area internationally around Australia for the last 20 years.
Oh, yes.
And a very important concept that has emerged is that of being person-centred. In other words, we don't talk about cases, we don't talk about demented people, etc. We talk about people and about listening to people. So I think it's just important that we don't talk so much about managing cases or managing. We're talking about helping people. Thank you.
Sure.
Thank you. Yes. Thank you, Matt. If you can.
My name is Monique Bond, and I'm a floater. So I work a bit with Keith and also with Antar, but it's mainly since Howard's 10-point plan when I got interested, and since then also going to court and just sitting there and listening to what's happening. So the point I wanted to bring forward, and may have been talked about this morning, was about the difficult for monolingual people to really understand people who speak a different language, and which I think is what is mainly happening with here in not just here, but in Australia, and that it's really difficult often to realise how little first people may be understanding, not just the normal words, but anything difficult like court experiences and anything that's out of the ordinary. And I really noticed that at the Palm Island hearings, particularly the coroner's report, where my husband and I were sitting there listening, and you could just tell that people were not understanding what was happening. There was one interpreter who talked mainly, to the court, and particularly then after the alleged the riots, there were some court cases, and I was sitting at some of those, and I'd say to the Indigenous people, I'm not understanding, what about you guys? Honestly, we had no idea most of the time. And I think that's a really important thing if we're talking about recidivism and prisons, to have that in mind and have that quite likely thing that you think you've made yourself really clear and actually, unfortunately, you haven't.
We've heard exactly that after some of the video conferences, court appearances from the jails. A young Indigenous fellow can come out, an officer may say, what sort of outcome did you get? And he may say, he has no idea.
Absolutely, absolutely.
Yep.
And that was really clear at anything I've been sitting at. And the other one was, again, after the Palm Island things, Lex Wharton and 5 other people pleaded not guilty about the court, the I've forgotten the word, but you're understanding what I mean. And only 6 people, Lex and the other 5, pleaded not guilty. All the others pleaded guilty because they said, we won't get a fair hearing anyway. And I think that's pretty shocking.
It's a great shame.
Thank you, Monique. Thank you. Yes.
Sorry. I know I've had more than my fair share already, but Keith Hamburger from Knowledge Consulting. I just wanted to build on something that Michelle said about the community hub and bringing those range of services together in a local area. And one of the key things in designing the community hub is to clearly specify the services you're going to use in that location and how they would work and interact, and you can do that by specification. And the other thing I wanted to say was that a critically important element in this is that it is run by the local community public benefit corporation, with the role of the public sector and NGOs changing to be one of capacity builder rather than doing, so that there is local ownership of those services.
Point well made, Keith.
Thank you, Keith. Okay, I'm going to conclude that session there. Thank you very much, Michelle, for presenting today and for your submission.
Well
Thank
done.
you.